Good afternoon, guys. Now, today's A discusses procedures that elderly folks no longer need. So, that is what we're discussing today for A. So, please join me today for discussion A. Here we go. Short answer. Recent reporting summarizes research showing that several routine screenings, procedures, and long-term prescriptions commonly given to older adults can offer little to little benefit while exposing them to harms such as bleeding, anesthesia, complications, painful treatments, hospital readmissions, and cognitive decline. So decisions should be individualized around life expectancy, frailty, and patient goals. Key findings from the study and related research. 3 routines flagged: repeat colonoscopies in very old patients, routine removal of common sun damage, skin patches, acne, keratosis, and continued use of some long-term medications. Example, low benefit thyroid replacement in certain older patients have been questioned because benefits shrink while risks accumulate with age. Colonoscopies after about age 75. Evidence suggests repeated screenings yields very small reductions in colorectal cancer mortality for many older adults, while procedural risks, bleeding, perforation, anesthesia, and complications from stopping anticoagulants can be meaningful. Acne keratosis treatment. These lesions rarely progress to invasive cancer. In average risk, older adults estimated risks 1 in 1,000, yet treatments, cryotherapy, typical topical agents, lasers can be painful and cause lasting irritation or discoloration. Surgery and hospitalization risk. Major surgery and hospitalization carry elevated short and long-term risks for older adults, including high readmission rates and possible impacts on cognition, frailty, and dementia. Increase these risks. Yale School of Medicine, the Lancettes. What this means for patients and clinicians. Individualized care evaluates life expectancy, frailty, comorbidities, and patient priorities before ordering routine screenings or continuing medications. Shared decision making. Discuss absolute benefits, numbers, likely harms, and alternatives. Watchful waiting, topical monitoring, deep prescribing, pre-surgical planning for older adults, considering surgery, assess cognitive reserve and frailty, plan for post-operative support and close follow-up. Because readmission and functional decline are common, practical next steps. Ask your clinician for absolute risks numbers, e.g., how many fewer cancers per 1,000 screened, and how the test or drug would change your care goals. Consider a medication review to reduce polypharmacy and stop drugs with low expected benefit. Numbers, ages, and study designs, and draft questions you can bring to your clinician. Recent, recent research warns that surgery and routine hospital care can, can cumulatively erode older adults' cognitive reserve, raising short and long term risks of delirium, accelerated cognitive decline, and possible links to neurodegeneration. Discussions about surgery should weigh life expectancy, frailty, and patient goals, not just disease specific benefits. What the study says. Quick summary. Scope. The article reviews evidence that as people age, they lose psychological and cognitive reserve. So, repeated exposure to surgery, anesthesia, and hospitalization can have additive effects on brain health. Core finding. Each surgical admission carries a measurable short term risk of post-operative delirium and functional decline across lifetime. Multiple admissions may increase the probability of persistent cognitive impairment and contribute to neurodegenerative processes. Key mechanisms and evidence. Delirium as a central event. Postoperative delirium is common in older adults and predicts worse long-term cognition, institutionalization, and mortality. Delirium episodes reflect low reserve and often reveal or accelerate underlying neurodegeneration. Cumulative exposure model. The paper frames risks as cumulative. Not every operation causes lasting harm, but repeated insults, surgery, anesthesia, infections, immobility can overwhelm compensatory mechanisms and unmask dementia. The Lancet. Okay. Cumulative exposure model. The paper frames risks as cumulative. Not every operation causes lasting harm, but repeated insults, injury, anesthesia, infections, immobility can cause overwhelm, compensatory mechanisms, and unmasks dementia. Frailty and baseline cognition matter most. People with frailty, pre-existing cognitive impairment or low cognitive reserve face the highest incremental risks from surgery. Practical implications. What patients and clinicians should do. Individualized discussions. Assess life expectancy, frailty, and baseline cognition before elective procedures. Quantify absolute benefits versus cumulative harm. Prevent and monitor delirium. Use multi-component delirium prevention orientation, sleep mobility, medication review, and screen postoperatively. Shared decision making. Discuss the cumulative risk of multiple admissions and how surgery aligns with the patient's goals and quality of life priorities. Okay, guys, that is A for you. I will be back on with B in a bit. For now, Gator Wellness. Take care, folks. Have a good afternoon. I will be back on shortly with B. See you guys shortly.